want to welcome everybody. Again, my name is Karen Freshwater, and I work at Bronson in Kalamazoo, Michigan. I will be talking about medication management, which, as all of you know, can be very challenging. I'll also probably have some duplications and things that have been said previously and that will be said later. And in the past, that bothered me because I thought, oh my gosh, we're saying the same things. But what I've come to realize is that a lot of times hearing something in multiple different ways really does help to learn and to process that information. And it also can trigger different questions that you have. So feel free, I'll have questions at the end. But if something really strikes you during this presentation, you have a question and you're afraid you're going to forget it, feel free to speak up, and I would be happy to answer a question at that point too. So again, we're going to talk about medication management. I think for a lot of people, when diagnosed with Parkinson's disease, for many, you may only be on one or two medications. So I think one of the most trying things is now suddenly, all your life you've been on one, maybe two medications or none at all, and now suddenly we're throwing all of these other medication suggestions at you. So my approach is always minimal medications. Take what you need, though, for quality and to keep you active and engaged. But what I typically don't like is to just throw a ton of medications at you and to work both in a holistic as well as a pharmacologic method. I'm not going to really go over the pathology because I think you've heard that now twice. But as you know, that by time there are actually symptoms, most people have had a deficiency of dopamine up to 80%, 50 to 80%. Different ways of diagnosing. Why do we want to diagnose it sooner? I'm obviously not going to go through this. I know you guys have the slides. It's a lot of words. I'm certainly not going to go over that. But the reason we want to diagnose it as soon as possible is because at some point we're hopeful to come up with a medication that can slow progression. And the sooner we can diagnose it, the better we're able to hopefully prevent the ongoing progression of the symptoms. The one thing, I don't know if anybody's mentioned this yet, but the most important thing you can do is exercise, which does potentially slow progression. So I'm always on my soapbox about good, rigorous exercise, no matter what stage you're at. The reason I am mentioning the atypical features of Parkinson is because that affects medication management quite a bit. So if someone has a diagnosis of Parkinson and there's rapid progression, typically Parkinson starts on one side and it's slowly progressive, but at the time of diagnosis, we're never sure, is this Parkinson's disease or is this one of those syndromes? So we're always monitoring. Every time we see you in the visit, we're looking, we're doing an examination, we're talking to you because we're trying to understand if this is following a typical progression for Parkinson or is it a more rapid progression. Is there early problems within the first year or two of symptoms that are suggestive of dementia or hallucinations? Are there falls early on? Are there early signs of the autonomic dysfunction that was talked about in the previous visit? So that orthostatic hypotension, the dizziness, lightheaded with standing that is severe. Are eye movements hampered? Maybe they're slowed and you're getting more double vision. Does the levodopa work, or if it doesn't work, because it should work if it's regular Parkinson's disease? So we want to recognize all of these potential symptoms that would not be typical for idiopathic Parkinson's disease because that's going to change how we manage with our medications. So just running through, there are different things that can cause these symptoms. There are drug-induced medications, some of the earlier antipsychotic medications, Tegretol, which is used, seizure medication, which is also used for pain and for trigeminal neuralgia. Many people have trigeminal neuralgia. Those medications can cause Parkinson-like symptoms. Progressive supranuclear palsy is what we call a Parkinsonism, meaning these are conditions which can mimic Parkinson's disease, but think of it more like a subset. So it has rapid progression, early falls, tightening of the face, like spasms of the facial muscles. One variant of this can only affect the lower extremity and cause significant freezing early on with walking. Multisystem atrophy, difficulty walking, difficulty talking. Smooth pursuits is the eye movement back and forth, whether they're smooth or are they jerky. And if you've ever seen anybody who typically were quite erect in their structure, but now suddenly is turning, that's called Pisa syndrome, and that's called from spasms in the back. Dementia Lewy body, this will cause early hallucinations. Normal pressure hydrocephalus, and vascular. So vascular Parkinsonism would be someone who has had stroke in the area of the brain that causes Parkinson's symptoms. So it would be in that basal ganglia area. And so this condition, typically you wouldn't see a lot of progression because it was caused by a one-time stroke. With all of these, if we even suspect, we always start with trying the levodopa, carbidopa, the Parkinson medications, because as I said early on, we think, okay, this is a Parkinsonism, we're not quite sure which, but we try to treat, and then we monitor to see what's going to happen. With the vascular stroke-like, sometimes there can be some mild improvement, but not always. With this kind of Parkinson symptoms, we typically wouldn't see a gradual progression unless there are subsequent strokes. So what are the different treatment modalities that we use? The pharmacologic, the medication, and non-pharmacologic, holistic. As I was saying, I like to do a combination because I don't think medications are always the best option. They're always a good option when needed, but we also want to focus on those other non-pharmacologic. And like I said, exercise is one of the really important things, a good diet. And to remember that not everything is Parkinson disease. I think that's always something that is easy to confuse. If any symptom that you have is thinking, oh my gosh, I think this must be my Parkinson disease. But unfortunately, you have to remember that anything else, so arthritis and gout, anything else that can happen also with Parkinson disease. So we have to always look at things with a broad view and not a narrowed focus of thinking Parkinson, because the worst case scenario is you assume everything is Parkinson and maybe that's not Parkinson and there's something you could do to actually improve that symptom another way. I think knee pain is one of the things I often get. And knee pain is typically arthritis, and so it's always good if there is a lot of knee pain, make sure you still follow up with the primary and with your orthopedic. There are still knee replacements you can get. I recently had a patient who was told they can't have a knee replacement because they have Parkinson. And I had to go to bat for them because there's absolutely no reason you can't have those therapies. But one thing to keep in mind is if you do have surgery, someone with Parkinson with surgery can have a little bit more difficulty coming out of the anesthesia. It can take a little bit longer, and it can promote more possibilities of hallucinations. And that resolves once you've come out of it. But I had one patient that I think it took them about twice as long to come out, and they did have some delusions and hallucinations, and it was quite frightening. But then remembering that's something that can happen with Parkinson helped them overcome that initial fear. But surgeries, there is no contraindication to surgical processes with Parkinson. So what are the different treatments? And I know these are talked about a little bit. I'm just going to go a little bit more in depth. But remember, too, that these are just suggestions and ideas. One of the most complicated things about treating with Parkinson is that every single individual is different. And my guess is that if we went around and asked every single person with Parkinson what they are taking, there would be variations, and we'd find very few who are the same. Because we treat the person, we treat how are they feeling, how are you feeling, what's going on, what is the timing of the medications, what stage. So it makes it complicated because there is no algorithm. There's nothing that we can say that shows you a printout that says, oh, you have Parkinson, do this. You know, with pneumonia, we give a specific antibiotic, we do it for 7 or 14 days, that's the end. But not so with Parkinson disease. As you know, it's constantly changing. It can change from even day to day. It can change based on what you're eating. It can change on your anxiety level. And so it's always difficult, and it's up to the person with Parkinson, and even more importantly with family, to help. Because the person with Parkinson doesn't always recognize some of the symptoms. You know, maybe they're not recognizing that they're shuffling a little bit more or that arm isn't swinging. So it's helpful to have family who is also helping to monitor and to see how you're doing. So they can say, you know what, it looks like maybe you're shuffling, and then to always think about timing a medication so you can determine if you're on the most appropriate medication. So levodopa, carbidopa. This formulation is the oldest. It was the first developed, and it's still the best. This is also called Sinemet. Rytari is a newer formulation of levodopa-carbidopa that is a capsule that has a combination of immediate and extended release caplets in it. And Duodopa is the newest, and this is a infusion, so it's a gel that's infused right into the intestines. With use of these, it kind of depends on what stage you're in, what's going on, and I will go over a little bit that later. So right now I'm just going to tell you the different forms. So non-dopaminergics, so levodopa is converted into the dopamine. So then you have dopamine agonists. You have the pramipexole, ropinirole, so that's Mirapex, Requip, and apomorphine. Apomorphine is an injection. You have MAOB inhibitors, selegiline, razogiline, and Xadago is the newest one. So that's the Azilect, for some of you who know those names better. COMT inhibitors, entacapone and Comtan. Amantadine, which is not actually approved, but used for dyskinesias, and there is a new approved extended release amantadine called Gocovri, which was just released recently. Anticholinergics, trihexyphenidyl and benztropine. Those are for tremor that does not respond to the levodopa-carbidopa. For some people, the tremor will respond to our initial attempt using the Sinemet, the levodopa-carbidopa. For others, tremor can be completely resistant to that medication, and so one thing we can try are these medications, trihexyphenidyl and benztropine, usually early on because they do have potential side effects later in the course of the disease. And then another new medication recently released is Nuplazid. Pimavanserin. It's the only medication approved for delusions and hallucinations, so it was really quite nice that we finally have something that's on the market for this. I don't know how many of you have seen the commercial for that. It's really a scary commercial, and I have complained to the drug reps for that because I don't think there was any reason to have such a scary commercial. And not everyone gets hallucinations and delusions, and so I can't tell you how many phone calls I got after that release because people were thought, oh my gosh, is that going to happen to me? But it doesn't happen to everybody, and sometimes it's medication caused by medications, and there's things we can do to help it, but I just thought that was a horrible commercial. So treatment side effects. This is anytime we're using medications, we have to think of the balance, risk versus benefit for everything. And every medication can be beneficial, but every medication can have adverse effects that maybe can make it not well tolerated. And when it does, sometimes there are adjustments that we can make to make it tolerated, or different medications we can try. So as I said, the levodopa-carbidopa, the Sinemet, Parcopa, Rytari, Duopa intestinal gel, those can cause nausea. The carbidopa and the levodopa is there, as the speaker before me said, to help with that nausea. And if you do get nausea, sometimes we can just give a higher dose of the carbidopa, and that will take care of it. Other times we can try something like Zofran, which is a nausea medication. But you want to avoid some medications like Compazine and Phentergan because that can actually worsen the Parkinson symptoms. The levodopa-carbidopa can have wearing off, and this simply means you've been taking it, but at some point it wears off. We usually start 3 times a day because it doesn't last. It's not extended 24 hours, so it wears off, and that wearing off period can vary. For the first few years, it might last 6 or 7 hours, but over time, you might notice, I'm due to take my medication an hour from now, but I'm noticing that my tremor is worse and I'm starting to shuffle. Well, that's because it's wearing off, and that's where I was saying it's really important for you and family to monitor, to be aware of when that happens, because then the answer is to shorten that interval. What you don't want to happen is to call and say, my medication's not working at all, and then have the dose increased when that's not the problem is wearing off. So you're looking at 2 things. Does it last for the length of time between doses? And is it effective? Let's say that about an hour after you take it is when it's at its optimum. So how do you feel at that point? So we either increase the dose or we shorten the interval. Dyskinesias are involuntary movements. I'm sure you've seen Michael J. Fox. They're just kind of movements of the head and the arms. Those are caused typically from the peak dose of the levodopa-carbidopa. Not everybody gets them, and it's typically preferred over the slowness and stiffness, and we do have some medications to help that. But again, not everybody gets that, and it's usually a peak dose symptom. So when that medication is at a peak level. The dopamine agonists, we have to be careful of those because they can cause impulsive control tendencies. So it's one of the things, if you are on pramipexole or ropinirole, the rotigotine patch, which is the Nupro patch, we always have to ask at each visit, are you having sudden impulsive thoughts that you didn't have before? Are you starting to gamble? Are you shopping on the home network and buying things that you never bought before? Now, some people do this anyway, so we're looking for a change. Are you buying more than what you didn't need before? Is it becoming a problem? Interestingly, there can also be sex addiction, so maybe there's never been a problem looking at pornography, but now suddenly there is. So these are things we always want to make sure that that is not happening because it can occur with this particular class of medication. It can also cause hallucinations, swelling in the ankles, and that orthostatic hypotension, which you talked about before, which means when you stand up, your blood pressure, everything drops, and then you get dizzy, lightheaded, and your risk for falls. The levodopa-carbidopa can also cause that. In fact, most of the Parkinson medications can cause that, including blood pressure medications and diabetic medications and Parkinson disease, so many things. And so when you have Parkinson and high blood pressure and diabetes, you are at extreme risk for that, so it's very important to monitor for orthostatic hypotension. MAOB inhibitors, razogeline, selegiline, Xadago, these medications are not used for a long, they can be used, their function is they slow the breakdown of the dopamine in your body. So what they, in effect, do is that they extend the amount of time that the dopamine is available. So they might have fewer side effects than the dopamine agonists. They're not quite as effective. They're also not as effective as the levodopa-carbidopa, but sometimes you can start with something like razogeline and Xadago. You do not have to use these in conjunction with levodopa-carbidopa. No evidence. There are I guess there's some debate, does razogeline slow progression? Because there was a study back in the past that showed potentially, but it's never really been confirmed, and I don't think anybody would tell you that that is the case. What happened is the one dose appeared to, but the higher dose didn't. So there's a lot of controversy about that and nothing proven, and they're doing a lot of research still trying to find something that actually slows progression. COMT inhibitor. This medication is another medication, much like the MAOB inhibitors, that slows the breakdown of the dopamine in the body, so it extends the length of time the dopamine is available. The thing to remember is that, and I don't always remember to say this, and then I get a phone call, but it can make the urine orange. So if you're taking this and suddenly you notice orange urine, do not panic. And it can also cause diarrhea. The anticholinergics, that was the benztropine, the cogentin, the artane, the medications that can help tremor, but they do not help slowness, stiffness, shuffling. These can help the dry mouth. These can cause dry mouth, fatigue, confusion, hallucinations, constipation, urinary retention. So they can actually cause a lot of symptoms that we can be associated with Parkinson. And so we'll try to use those early on. But as the Parkinson progresses, often these are one of the first ones we have to remove if those conditions start getting worse, especially confusion and hallucinations. And then amantadine and gocovri, that's the newer extended release, can cause hallucinations. It's typically really well tolerated. It can help the dyskinesias. So constipation, the livedo reticularis, that is nothing that's a problem, but to be aware, it's a reddish rash that can form on the legs, the shins typically. So it's not a problem, it doesn't cause any, it's just you might be nervous if suddenly you see that and you're like, what is that? So again, the gocovri and amantadine are used for dyskinesias. So there's a lot of options, a lot of variations in how we will treat somebody with Parkinson's disease. And it depends on the age, so it depends on presentation. So when somebody first comes in the office, what's going on? How old are you? What are you trying to do? Is it somebody who's still trying to work? Is it somebody who's more advanced? Because sometimes, as you know, the symptoms can be kind of subtle, and people tend to have a tendency to say, well, I'm just getting older, and they kind of blow it off. So by the time somebody gets the diagnosis, it might be a little bit later in the course, or it can be someone who just has refused to go to the doctor forever. And so we always look at the individual, because as I said, there's no set paradigm for how we are going to treat. So if somebody comes in, let's say, and they're mostly just the tremor, a little mild rigidity. Rigidity is the resistance of the muscles to move. So I know when you guys are being seen, typically part of the exam is going to go like this, and they're looking to see how freely does the arm move. Is there resistance given by the muscles? So that would be rigidity. Someone maybe less than 65, you can start with a dopamine agonist, the Requip or the Maripex, or Razogeline or one of those others. If it's just tremor and there's nothing else, you can try the Artane or the Cogentin, see if that helps. If they're over 65, depending on the level of symptoms again, so over 65, maybe a little more significant symptoms, probably we would start with the levodopa-carbidopa, but maybe we try that and there's nausea or it's just not tolerated, then we can also start with a dopamine agonist and try that as well. Dopamine agonists, think of it as something that kind of mimics the dopamine. So overall, not quite as effective, but can be quite effective for the right people. If symptoms interfere with activities of daily living, so there's enough slowness, enough stiffness, maybe dragging a foot or falling, then we're going to always start with the levodopa-carbidopa, the Sinemet, because it is the most effective, and we want to have that person at their best. So we've talked a little bit about wearing off, and the previous speaker kind of hit on this as well. So remember, at the initial presentation, typically we'll start, and I'm just going to go with the levodopa-carbidopa, because that's the one we watch for the wearing off the most. Initially, maybe for the first 3 to 5 years, you're taking it. There's what they call the honeymoon period. Everything is perfect. It's lasting 6 hours. You're taking it religiously 3 times a day, and it's doing great. But as it progresses, and this is more a function, it's not, because I get this question a lot, if I start the Sinemet later, will that mean it will work longer? And that is not the case, because the wearing off, the need to increase the dose is more a function of the progression of the disease and the loss of more of those dopaminergic neurons. It's not because the medication starts being ineffective. So as it progresses, the duration declines. So we might start off, oh, I'm doing really fabulous for 6 hours between my doses. And this is why it's important to try to be consistent. You know, don't make it your life goal. My gosh, I have to take it at 6 hours, but I'm going to be gone. You know, you can take them with you so that you have them with you if you need it. But if you forget, you don't want the pills to manage your life. You still want to have your life. But try to be as consistent as possible, because that's what's going to help you to understand how well it's working and when it wears off. So over time, you notice that it's not working as long. So then you shorten the interval. So we started off 3 times a day, and now it's wearing off at about 4 hours. And now your last dose, let's say, is at 4 p.m. And now you're going to have wearing off later in the evening. So we'll go from maybe a 6-hour to 7-hour interval. Now we're going to switch it to a 4-hour interval, and we're going to add a 4th dose on in the afternoon. So we always make these adjustments where our goal is to keep you as controlled throughout the day as possible. So monitoring, keeping a journal can be helpful, because it is hard to keep up with that. And just, don't be crazy. I don't have to journal every single day, but every now and then take 2 or 3 days and just say, you know what, for 2 or 3 days I'm going to be super consistent. I'm going to journal. I'm going to put down when I'm taking my medication, and I'm going to pay attention to my walking, my hand movements, my manual dexterity, my tremor, and mark down, all right, when are these symptoms worse? And that way you can confirm just how long that's working and can help in your treatment process to know, ooh, yep, that's right, about 45 minutes before I'm getting worse. And that puts you at risk for falls. So if it's wearing off and now you're stumbling in a little more and you're dragging that foot, you're at risk for wearing off and just feeling a little slower in general. So shorten the interval. And as for me, and I think, well, I can't say everybody, but as for me, if I'm seeing somebody, typically I'll do 3-month intervals early on, and then it might go to 6 months, very few annual. I usually let the person dictate what the need is. In my opinion, you notice wearing off, call the office and say, hey, I've kept a journal. I don't have an office visit for 2 months, but I'm having wearing off. And I think most providers would say, okay, go ahead and shorten that interval, and if you need the 4th dose, would go ahead and add that. So don't think you have to wait until an office visit to make sure you're optimally controlled. So in advanced disease, let's say greater than 10 years, the response gets more narrow and more narrow. And for some, it ends up being every 2 to 3 hours, which can be quite burdensome. And some will choose to do that. Some will choose to say, yep, okay, I'm going to just take it every 3 hours. But then there are other options we can do, and I'll talk about that in a little bit too. So document when the symptoms increase or additional complications. Is it prior to the next dose? Are you getting dyskinesias? When are those dyskinesias occurring? And then when you go to your office visit, have those notes with you, because that's what we want to know. We want to know, do you feel like you're stable throughout the day? Do you feel like you're having times of the day when you're stumbling more or your manual dexterity is not as good? The first thing we're going to do is we're going to say, okay, well, what time are you taking your medications, and are you being consistent? Are you taking it on an empty stomach, because we know that protein can interfere with the absorption? Or somebody who has a lot of constipation and it's not well controlled will also interfere with absorption because it slows the progression of the medication into the intestines. Let's say you're somebody who's pretty well controlled, but every now and then, and maybe it's because just because of life situations, you were late taking it, or maybe you just didn't have a choice. You had to take it with your meal and it's not working quite as well. You've had some wearing off and you're not doing as well. So take one of your Cinemets, levodopa, crush it, put it in juice or apple juice, and that will make it work more quickly, and it'll kind of give you a jump start to help smooth you over until that is your next official timing. But as she said earlier, don't just skip it. If you're late, take it when you remember it, and then typically I'll say then adjust your intervals accordingly. Atypical injections, I have not used it yet, but I know others who do. And this is it's one of those dopamine agonists. It's for sudden wearing off. You give the injection, it purportedly works then a little more quickly, and it again acts as a bridge as the crushing of the levodopa would do. So what if the medications fail? You're having a lot of fluctuations. You're coming into the office, you're saying, oh my gosh, it's working. It worked really well yesterday. The day before that, I was just all over the place. I was having dyskinesias. It was wearing off. It doesn't seem to have a rhyme or reason. I've kept a journal. I'm trying to be consistent. Well, then we can try medications like Rytari. Rytari is the one that I discussed that has the combination of immediate and extended release caplets. That's still a 3 or 4 time a day medication, but it helps to smooth those fluctuations out. You can add a dopamine agonist. I usually won't do this if it's later in the stages of the Parkinson, just because I have concern for the hallucinations and the impulse control and other side effects from that. You can add a Comtan that we had talked about, or the Razogeline. Typically, and the fluctuations, that's going to depend on what stage of the Parkinson you are in. So let's say the medications no longer adequately control the motor symptoms, or the dyskinesias are just disabling, and we've tried the amantadine and the Covri, same thing, one's extended release, and we just can't get the dyskinesias controlled. We've switched to Rytari to try to smooth out how things are working. Still, the dyskinesias are a problem. Then there's things, the DBS and the Duopa, and then there's a workup for that, and I'm not going to go into that because I know that there are talks about both of those throughout the day. One of the things for the DBS that what happens is you wait too long because there are specific criteria for that. You have to be well controlled with use of the levodopa, but having fluctuations. The dyskinesias, the only thing that doesn't matter is tremor. If the tremor does not ever respond to anything, it doesn't respond to the levodopa, carbidopa, the Cinemet, it doesn't respond to a dopamine agonist, it's not responding to the other medications that we've talked about, then DBS can actually help the tremor even though medications have failed to respond. And then the Duopa, which is the infusion, and I do know there's a talk kind of dedicated to that, so I'm definitely not going to go into that. I'm just going to briefly, I know the previous speaker touched on all the non-motor symptoms, so I'm just going to run through those pretty fast. And again, remember that these are just ideas. These are things that I think about, but every provider is different. So, and everybody has their own preferred management routine. So make sure you talk to your provider and ask questions. Always ask questions. Education is your best friend. Okay. So the REM sleep behavior disorder, as she had said, melatonin is always the first thing we try because it has the least potential for side effects. Start with 3 milligrams. You can go up to 10. Take it at least an hour before bedtime, hour and a half. There are regular release melatonin, and there are formulations of extended melatonin. So if you're somebody who falls asleep quickly but wakes up, look for that extended release. If you can't fall asleep, but once you're asleep, you do well, try the regular melatonin. Sometimes we will end up going to clonazepam at a very small dose, but we have to be careful with this too because we don't want to overly sedate you at night because if you have to get up and you have to use the restroom, we don't want to sedate you to the point where you're going to have confusion if you wake up or it's going to put you at risk for fall. A lot of times we will have somebody consult with our sleep provider just to make sure of what's going on and to help also with the sleep hygiene practices. And if you have sleep apnea, definitely get that treated. Sleep apnea is going to cause increased fatigue, which is going to increase your symptoms, and it also puts you at higher risk for stroke. Constipation, I would say 98% of people with Parkinson have constipation and will use Miralax daily. Sometimes I'll get a little bit of concern because if you read the label, it says, oh, if you take it more than 7 days, consult your provider. Well, that's because if somebody doesn't have a known reason for constipation, then you should consult your provider. But we know that Parkinson causes a slow transit time and leads to constipation, so it's okay to take this every day. High fiber diet, plenty of fluid, exercise is so important. And if you're a coffee drinker, coffee first thing in the morning can also stimulate having a bowel movement. So start with fiber, add Miralax, and if you need to, you can add Colace. So I have some individuals who will do Miralax in the morning, and then when needed, we'll do the Colace in the evening. Exercise, plenty of fluid, 2 most important things. Anxiety, very prominent, and anxiety, when I'm talking about wearing off, the first thing you're thinking is, am I getting slower? Is the tremor worse? Am I dragging a foot? How am I thinking? Does my thinking seem a little slower? But for many people, anxiety can be a wearing off symptom. So if you are one of those individuals who seems to have anxiety, but you haven't figured out, well, why does it just happen? Pay attention to that when you're doing your journaling because that could be one of your symptoms of wearing off. And there are different medications, but we have to be careful with all medications in Parkinson because some can worsen the symptoms. Benzos, that's Xanax, Ativan, we really don't like using these, but sometimes we do need to at least try something for somebody who has extreme anxiety and we're not having much luck with other. And if it's really debilitating, we will pull psychiatry in to work with that. Apathy. Apathy is one of those that she had talked about that is problematic. Sometimes, though, I find that it's more problematic for the family than for the person with Parkinson because they don't care. But the family sees them not caring, and that makes them stressed. So a little bit, we understand it's going to happen, and then you just have to find that motivation. It's just that part of the brain. It's part of Parkinson. You just have to remember that that's causing that. It's not that they don't mean to not care. It really is part of the Parkinson. So, find stimulating activities that are able to be enjoyed. Exercise is always going to make a difference. Find a group exercise, and I prefer group exercises only because then you're held accountable. I have seen great friendships form in exercise classes. We have a couple of exercise classes in Kalamazoo, including to delay the disease and dance. And the individuals that take part of those tell me that one of the things they feel are most important for their symptom management is that camaraderie that they develop. And exercise definitely helps with symptom management as well. Fatigue, very difficult. As the previous speaker said, if you need a nap during the day, take one, but it shouldn't be 2 hours long. Set an alarm, set it for 20 minutes, maybe 30, but try not to take a nap for longer than that, because as we all know, if you take a nap for too long, you wake up, you're groggy-headed. So a short nap is okay. There are medications that can be used for fatigue. They're off-label, often are not approved, but sometimes we do go towards those if we are really struggling. The drooling, I would, before you try medications, try to suck on a piece of sugar-free hard candy, chewing gum, because the problem is that you're just not swallowing automatically. Just like everything else is slowed down, the swallow reflex is reduced. So we swallow all day long, we don't think about it. But with Parkinson, you don't. So if you have hard candy or chewing gum, that helps stimulate you to remember to swallow more often. If that doesn't work, the atropine drops under the tongue and the Botox. Some people really complain a lot about excess phlegm, and you can try something like Mucinex for that. Urinary frequency. This is difficult because many people with Parkinson have urinary frequency and urgency, and this also can be a sign of wearing off, so monitor that as well. The problem with this is that the medications we use for this symptom are those anticholinergic medications that can cause dizziness and constipation and fatigue and nausea and blurred vision, all of those. So it's very difficult to treat with medication. There is a new medication called Myrbetrix. It's probably been out probably over a year now because time flies, and I think it was just yesterday, but it wasn't. It actually does not have those anticholinergic effects, but it also can be expensive. Sometimes we're able to get it approved through like prior auths, but these are all things to talk to your provider about. And you can also, I don't know if everybody has access, but a lot of urology clinics have a group of them. Ours is called the Continence Center, and it's staffed by nurse practitioners and a physician, and they work on strengthening the pelvic floor muscles. So this is another reason exercise can be very helpful. You want to strengthen the pelvic floor muscles. So think of it as Kegels on steroids. And that can help, because if you strengthen those muscles, it's going to help with leakage. And men, you too can do Kegels. There are specific Kegels. So, orthostatic hypotension, I think she went into that quite a bit. But it is a problem. It can lead to falls. The medications can worsen that. The different comorbidities, as I said, so diabetes, high blood pressure, et cetera. So watch for this. If you stand up and you're getting dizzy and lightheaded, number one, make sure you're drinking plenty of fluid. A tendency is to not drink enough fluid because you don't want to have to run to the bathroom every 2 hours. But then you become dehydrated. When you become dehydrated, your blood volume drops, you have more dizziness with standing. So as difficult as it is, and I hear this all the time, I don't like water, use the lemonade, the packets in there, but just try to drink plenty of water. And if nothing else helps, then there are medication adjustments we make. Often the blood pressure medications end up getting adjusted, sometimes stopped completely because the blood pressure tends to drop. And it is a challenge, and we do have to keep this in mind and work with this a lot. For the elevated blood pressure with lying down, elevate your head of your bed so that you're not flat. Avoid decongestants because that can make your high blood pressure worse. Just don't drink fluid 2 hours before bedtime. Try to drink it earlier. Don't forget to take off your compression socks when you lie down, because remember, your compression socks are for that orthostatic hypotension. They're to help shunt the blood and fluid up to your brain when you stand up. So you don't want those to be there when you're sleeping, and especially if you're flat. And then depression, she had talked about already, so I'm not going to go over that, but it is difficult to treat, but important. And you can do therapy. I always say I know people don't like to go to therapy, but I think it's always helpful to have somebody who's not invested to talk to, so that somebody you can just say whatever you want. Maybe you feel guilty because your spouse is having to help, or you don't want to talk to your family about some of the things. A good therapist can be so valuable. We already talked, so the psychosis she touched on too, the medications, I hit on that. So non-pharmacologic, what can you do that are not medications? Physical therapy, occupational therapy, speech therapy, so important. The LSVT, big and loud. Those are very intensive therapies, but they are very helpful, and what I prefer is somebody doing that and then segue into a really good exercise routine. So they will help you. They'll help you figure out this is how you should exercise. This is what can be helpful. But you have to keep it up. If you don't keep it up, you lose it quickly. So exercising, rigorous exercising, so you want to make sure you get your heart rate up too. Those are the things that have shown to help with the symptom management the most. And it can help with depression. Obviously, that can help with other comorbidities, your high blood pressure, your diabetes, and it most definitely helps with symptom management. And I can tell you without any hesitation that of my patients who exercise regularly, so 4 or 5 days a week, I do not have to change their medications nearly as often. We've had our Delay the Disease exercise class now for 5 years, and I have a staunch group of people who have been in that class religiously since its onset, and 90% of them, I haven't adjusted their medications at all. So music therapy can be good because that can be relaxing, and the beat of the music can help with movement. So it can actually help stimulate you to walk better, and remember to swing your arms. Massage, tight muscles, all that tension, anxiety, massage can be good for that, and I think if insurance companies were smart, they would pay for everybody to have massage, but it's probably why I'm not in the insurance business. So cognitive behavior therapy, biofeedback, these are forms of therapy, non-drug approaches that help your body to change how it responds to the stressors. And I have a few individuals who are doing that, and they do feel it helps they feel it helps their tremor, more because it helps, I think, the anxiety and the stress, and then that helps and secondarily. A nutritious diet. There are a lot of studies now on diet approaches. Does diet impact symptom management? Does Parkinson's disease start in the gut because they have found the alpha-synuclein in the gut? That's still out for debate, but we do know that what you eat impacts how you feel. We know that a bad diet increases inflammation within your body. So a nutritious diet, Mediterranean is usually the one I would suggest, because it's based on a really healthy lifestyle and diet. So a lot of fruits, vegetables, the good oils. And don't forget your support structures. Everybody's afraid, and I understand that too, to ask for help. But think of it as a win-win, because people want to help. They want to understand what you're going through, and so they need that education because they don't understand. So the support groups, churches, family, friends, don't hesitate to ask for help and let people help you. I think there are other talks on things in the pipeline. So basically, I think the most important thing to know is that there's so much research going on, and there's a lot of hope in the future, a lot of optimism, because there is so much going on. I think we will come up with something that's neuroprotective. They've done a lot of studies and a lot of different medications that have not panned out, but I think it's only a matter of time. And the most important thing you can do, keep a positive attitude, stay engaged, and eat a healthy diet and exercise. So I'm just going to do a quick, so I know it's hard. This is a lot of information. I don't see a clock. I don't know how much time I have.
5 or 10 minutes.
Okay, that's perfect. All right. Let me go through a case study to try to wind things. I'm hoping that this will help you to put everything together a little bit. And I can't do every scenario, and these are just right out of my head of common things that I see. So the first one, a 65-year-old right-handed man noted tremor of the right hand when he was driving and holding the newspaper, and also just when resting in his lap. He's had right shoulder pain for 6 months. A lot of times that's one of the first symptoms, right shoulder pain, and they go into their doctor and they say, oh, it's rotator cuff or it's frozen shoulder. But a lot of times that's because that's the arm that's affected and you're not swinging it and then it gets stiff. He's noted constipation and reduced sense of smell that's actually been going on for several years. When I look at the patient, he has a poker face, and I know you've noticed this, it's somebody who maybe used to be very animated, but now you're really kind of unsure of what they're thinking. And I've had families come in and they felt horrible because they thought this person, their dad, was angry all the time, but it wasn't that. And they were so relieved to find out that, no, that's just part of the Parkinson. It's not anger, not angry. The expression is just hampered. So blink rate is slowed. There's a soft voice, mild rigidity at that right elbow, so a little bit of resistance when I'm trying to move it, a very low frequency tremor. And his movements are slower, so when we do this hand's like this, and this one was like that. Walking is good, no problems with balance, no problems in general with quality of life. So he was diagnosed with tremor-predominant idiopathic Parkinson disease based on those cardinal features. It's one side, there's some slowness, there's some stiffness, and he had the constipation, reduced sense of smell earlier. So because they're mild, they're not interfering with quality of life, we talked, do you want to start a medication? He says the symptoms don't really bother him, and he would prefer not to. And that's okay, and that's what's important to know. It's okay. The medications are for symptom management, and if things are mild and you don't want to start something, they're not going to change progression. But if they are impacting, then you do want to start it. So he elects not to. But I did tell him he needs to start a rigorous exercise, and so he says he will do that. So he returns to the office in 6 months. Tremor has increased. Notice the walking is slower, and sometimes now he's stumbling because he's not quite picking up that right foot as well. The swinging of the right arm is still not very good, and it's noticed that the manual dexterity is not good, and he's right-handed, so he needs that right hand dexterity. So we started to discuss medications. He's young, still working, and so I elected to suggest levodopa-carbidopa because it is the most effective. He's still trying to work. We want to keep him optimized. And so that's what he started, and he reminded him to take it on an empty stomach at least 30 minutes before a meal, hour and a half after, and that varies depending on what is being eaten. A small snack, non-protein, if there's some nausea. I referred him for physical therapy because that can also be educational for him to help him to recognize what the symptoms are and to help develop the most appropriate exercise routine. He returned in 6 months. Medications helped with slowness and stiffness and dexterity, but the tremor is still prominent. It's just not responding. He did do the LSVT big, and it was very helpful, so I started him on a low dose of that trihexyphenidyl. Because he's young, I'm not too concerned about confusion, but he was warned to watch for that. He came in another 6 months. Medications helped with slowness and stiffness. Tremor is improved. So he continues to exercise 4 days a week, and he's remained controlled for the next year. So 2.5 years later, he's taken the levodopa-carbidopa 3 times a day, every 6 hours, but he notes the increased slowness and stiffness occurring about an hour prior to that next dose, but other than that, he's doing fabulous. So we shortened the interval to every 5 hours, and he continues on the tremor medication. And then another year, 3.5 years post, he has worsening symptoms, wearing off at 4 hours, and he has had 1 fall. His voice is soft and speech is not clear, and sometimes he will choke. So we talked about good swallow hygiene, tucking the chin, small bites, avoid dry foods. We increased the levodopa because overall, it's not wearing off now, it's overall he's not feeling as well controlled. So we increased to 1.5 to 2 tablets 4 times a day at 4-hour intervals. He's continuing to exercise, and I sent him back for physical therapy. So you can always go back to physical therapy and repeat that LSVT loud, especially if you have kind of fallen off the wagon and not exercising as much, and you just need that Kickstarter and that boost to get you back in there. And he also, and the speech therapy. So he also went back to the speech therapy, LSVT loud, for the voice, and they also help with the swallowing. 6 years post-diagnosis, he continues on the 2 tablets 4 times a day, plus the trihexyphenidyl, wearing off at 3 hours. He's noticed some difficulty rolling over in bed, and he's very slow first thing in the morning, and he's noted a little bit of drooling. So we added a CR. So I didn't talk too much about CR, levodopa-carbidopa. CR is controlled release. So the idea is that it's extended, and it's similar to the Rytari, but what happens with the CR version is it doesn't have a nice, smooth absorption. It tends to fluctuate a lot. So we don't use it much during the day, but we can add that at bedtime to see if that helps in the event that someone's waking up in the middle of the night and having a lot of stiffness or slowness. Another thing many prefer is just take another dose of the Cinemet if you wake up at 2 a.m. because you probably do have wearing off. Take it again and then go back to sleep and then resume the next day. So many times I'll write the prescription as take 4 times daily plus additional 2 tablets if you wake late at night and are finding yourself be slow and stiff. And then he's going to try to chew gum and suck on sugar-free candy to help with that excess saliva. 10 years later, 75 years old, increased to 3 tablets 4 times a daily, 3.5-hour intervals. He's having dyskinesias now. He's at the peak dose, along with some confusion and worsening constipation. We discussed trying the Rytari, which is that combination, and adding amantadine for the dyskinesias. The tremor medication, that trihexyphenidyl, is stopped because of the worsening confusion and constipation. And so he switched to Rytari, saw improvement for a couple of years, and came back, and then we discussed DBS versus Duopa. Do you want another case study, or do you want to ask questions? All righty, go ahead.
Yes. If your let's say your left arm, it's a symptom that it's not moving when you're walking. Is that a permanent condition, or can that be improved, even get back to normal with medication or exercise?
Well, medications and exercise can help, but it's a permanent condition in that because of the Parkinson, there's not the automatic response of swinging the arm. So you have to focus on it more, but keeping your medications at a good interval and then exercise will help you to remember to focus on swinging the arm. And it's one of those things, and everybody says across the board, I do it, but then as soon as I stop, because maybe you're distracted, then it stops swinging again. So unfortunately, it's one of the things to think about, but it is important to work on because that does affect balance, and you want to keep that arm loose.
I think we only have time for one more question.
Can you add any agonist on this?
Add.
This patient.
Oh, can I add on an agonist?
On this?
So that's one, yes. So a dopamine agonist can be added. I typically won't add it later in the more advanced stages because of concern for potential side effects, but especially early on. Sometimes I will add, especially if somebody doesn't tolerate the Cinemet or we're not wanting to push the doses because he's very young, then sometimes I'll add that. I might add that with the levodopa. And you can also just start with that. So it's really very individualistic, and we talk and it's a mutual decision when we discuss the medication, the potential side effects, and how much control, what is the lifestyle. The dopamine agonists, you don't have to worry about food so much. There's the extended release and the regular. Sometimes that's used if somebody has restless leg syndrome, and so that they might already be on that in the evening at bedtime. So a lot of it is really provider, and hopefully it's a partnership between the provider and the person with Parkinson to discuss what is the best medication regimen to be on. Oh, can I do one more? She just has one more.
I noticed that protein interferes with medication. Is it better, can you still eat the protein, like in between, like you're taking your meds 4 hours apart, to have your med and then wait an hour and then you can have protein?
Yes. So the question is it okay to still eat protein? Because we know that protein can interfere with the absorption of the levodopa carbidopa. And yes, protein is really important. It's an important ingredient in your food diet, in your diet. So it's perfectly acceptable to have protein. You just don't want to, if possible, eat it at the same time as you take the medication. So take your medication 30 to 45 minutes before you're going to have a high protein meal, or an hour and a half after. So you want to give that protein time to get out of the stomach and not interfere with the absorption. All right, thank you.
Thank you very much. Thank you very much.